Hello. Today we will be discussing about the ROP, the retinopathy of prematurity, which happens in the babies which are born preterm, that is less than 36 weeks. Uh, Time period between 30 weeks to 32 weeks is called as 34 weeks is called as preterm, and more than 34 to 36 up to 37 weeks actually it's labeled as late preterm. So this is a person, Theodore Laster Terry, who first described ROP and differentiated it from PHPV, persistent hyperplastic primary vitreous. He differentiated ROP in that it occurs in premature babies, underweight babies. It's mostly bilateral and happens in early months for life. In the 1950s, the role of oxygen was established in the pathogenesis of ROP, and rapid weaning of oxygen was also found out to be a risk factor, independent risk factor for ROP. There have been three epidemics in ROP. The first epidemic was in developed nations in 1940s to 1950s, when there was unmonitored oxygen supplemented to the newborn babies, especially the premature children. The second epidemic happened in 1990s in the in the developed countries, where the survival of the weak babies was more. And the third epidemic is presently happening in the developing countries like India, where the severe ROP has been seen in comparatively bigger babies. Next, we come to ROP classification. When we classify ROP, we divide into stages and which zone the vessels have reached. The stages are defined as stage 0, in which there is no ROP. In stage 1, there is a demarcation line between the mature and immature retina. In stage 2, there is a ridge, that is a two-dimensional. Ridge means the width of that line has increased between the mature and the immature retina. The stage 3 is the 3D, though that ridge also has now height, and fibrovascular fronts are seen there. The stage 4 is the RD stage, that is the retinal detachment stage, and it is labeled as stage 4A when it's extrafoveal, extramacular RD, and stage 4B when it's a macula involving RD, and stage 5 is total RD. ROP is classified into zones depending on where the mature vessels have reached. So there is how to because the vessels grow from the disc, the vessels grow from the center of the disc centrifugally. That's why the retina can be classified into three zones. The first zone is made with disc as the center, and the radius of this circle is twice the distance between the disc and the fovea. Twice the distance between the disc and the fovea is the radius of this circle, and this circle is labeled as zone 1. The second zone is the circle whose which is tangentially touching the nasal periphery at the ora. And the third zone is the whatever retina is left in the temporal area, superior and inferior area in zone 2 is labeled as zone 3. If the ROP is in the center, that is zone 1, is worse than zone 2, and zone 3 ROP is less worse than zone 2, and zone 2 ROP is less worse than zone 1. What are the symptoms in ROP? The first symptoms which can be seen in ROP babies is poor cognitive development, because they are preterm. That's why their cognition is also, milestones are also delayed, and they have poor cognitive development. Other things which can be noted in ROP babies is myopia, amblyopia, squint. What are the risk factors? The main risk factors for ROP is prematurity, that is the gestational age less than 34 weeks, and weight less than 2000 grams. It is not that ROP will not happen in the babies more than 2000 grams. It can happen in those babies also, provided some other risk factors are there. Who should be screened and when to screen? All the premature underweight babies should be screened. Uh, the screening should be done at the 4 weeks postnatal age or 28 weeks of post gestational age, whichever is earlier. And the ROP management we can do with laser, anti-VEGF, surgery, or post and we also need to do the post treatment care after doing all these managements. What are the alternatives to screen the babies, which have now been taken into consideration, that the low birth weight gain proportion babies should be screened. How to calculate this low birth weight gain proportion? Weight of the baby at 6 weeks minus the birth weight divided by the birth weight. If it's less than 50%, that baby should be screened. The second algorithm is Win ROP algorithm, in which if the body weight increases and the serum IGF-1 levels are more, we should screen those babies. The third alternative is ROP score, in which we have to consider everything: the birth weight, the gestational age, the weight gain, the blood transfusion, uh, if needed between birth and up to 6 weeks, and the use of oxygen post delivery. The fourth alternative, which can be used for ROP screening, is telescreening using the paramedical staff, in which they can click the photos using the red cam and send it to the retinal surgeons or the ophthalmic surgeons to grade the ROP. What are SNCUs? SNCUs. SNCUs are sick newborn care units. Sick newborn care units. They are almost 12 to 20 bedded units, and the government has a plan to start this sick newborn care units at the district hospitals, and there will be a data entry operator who is the CMO, Chief Medical Officer, which will coordinate with the ASHA worker at the ground level, and also this data entry operator will send alerts to the alert SMSs to the patients directly, so that they don't miss the ROP screening. This data entry operator will uh, give all the details to the CMO, and CMO will further coordinate with the ASHA worker. And the second thing, which can be hub and scope model for the ROP management, in which the hub, that is the main ophthalmic surgeon, and the scope is the ASHA workers, the other trained personals, the optometrist, who will look around taking photos with the red cam, doing type of telescreening, and whichever babies need treatment, or whichever babies need further evaluation, they will be sent to the ophthalmic surgeon directly. So the first modality of the treatment was laser. What laser can be used for the treatment is both diode versus green laser can be used. Green laser is what? Frequency double ND YAG laser of 532 nanometers. It can be used. Diode laser is a red laser. So we have this study from Sangi Chi and Dogra Emso and Vinekar Ray, in which they studied so when we see the difference between the diode versus the green laser in the group A and the group B, the group A was given the frequency double ND YAG laser of 532 nanometers, and the group B was given the diode laser. In stage 2, ROP, around 34%, and but there was no difference in both the groups, no statistically significant difference in both the groups in stage 2 and stage 3. Zone 1 and zone 2 also, there was no statistical difference between the two groups. So there was no difference whether we use frequency double ND YAG laser versus the diode laser. All the things, that is the pre-threshold, threshold, clock hours, how many clock hours are involved, tunica vascular lentis, and the pre-retinal or vitreous hemorrhage, all were almost same, and the results were almost same. uh, how to do it? Some people tell it's better to give baby 5 to 10% dextrose or sucrose 24 while doing the ROP laser. We can mummify or swaddle the baby using the sheets. We can mummify the baby, swaddle the sheets, so that baby does not move his hands too much. And when doing lasers, what thing we have to take into account, that all the laser marks should be only half burn width apart. It should not be normal in adults. For PRP, for diabetic retinopathy, we are using one burn width apart, but for ROP, it's only half burn width apart. And we have to laser all the avascular retina. It's not like we have to laser on the periphery, or we have to laser only at the ridge area. We have to laser all the avascular retina. And tunica vascular lentis. What is tunica vascular lentis? Tunica vascular lentis is a congenital vascular structure just behind the lens. And some people say that tunica vascular lentis is there, we have to give anti-VEGF. But before giving anti-VEGF, we can always try a massage spreading technique in which we massage around the eyeball. Using a depressor, we massage around the eyeball. We start from the posterior of the eyeball to the interior, and sometimes the pupil dilates, and we can avoid anti-VEGF. And once the pupil dilates, we can go for ROP. The aggressive ROP is another indication for going for laser. We can do laser in a single session treatment. Like this is a pre-retinal flat neovascularization around zone 2. And we can always laser all around, and we don't laser the neovascularization area. That neovascularization area we don't treat directly. What we have to do is we have to laser all beyond that neovascularization area, because that neovascularization area might have intraretinal evasions. So we are not directly lasering it, but we try to cover maximum. The What is the second option? In second option, we laser only beyond that neovascularization area. We let that neovascularization regress more, and second laser we add on at the second sitting 5 to 10 days later. In the first single session treatment, we laser directly on the neovascularization area also. What we follow in our practice is the second option, in which we do it step by step. We first laser all the avascular retina, let neovascularization regress a bit. Once the more retina is available, we add on the laser spots. So, how to decide whether to do anti-VEGF or laser? We can, when we are in a dilemma that it's fovea involving or non-fovea involving avascular retina, see, we can always plan FFA, and if the fovea is perfused, we can directly go for laser rather than doing injection. We have to laser around the aura, and we have to go posterior aggressively only if nasal superior and inferior ROP or avascular retina is too much. We have to laser only around the aura mainly. What is FVP? If FVP is there, there is a chance of crunch phenomena. There is a chance of crunch phenomena. So we should do a thorough laser and leave no skip areas. If on FFA there is avascular fovea, we can always plan anti-VEGF, and we can give anti-VEGF till the vessels reach zone 2 interior, and then we can see that if any leakage is there on FFA, and then we fill in with PRP. We have an example like some baby is treated with laser and still that baby has an active ridge. What to do? We can do secondary posterior laser posterior to that ridge in a vascular retina and also in the skip areas away. And how much away? Around 1.5 width away from the ridge. And this posterior laser can be done primarily in the first sitting or in the secondary sitting when the active stage is not improving. Next, we come to the anti-VEGF treatment in the ROP. ROP is the leading cause of blindness in the childhood as of now. It's not any other, but this is the leading cause of childhood blindness presently. We have different trials in which anti-VEGF were tried. One is the BEAT ROP trial, the other is the Rainbow trial. In BEAT ROP trial, Avastin was used, and the primary outcome was recurrence of ROP requiring treatment after anti-VEGF versus the laser. What is the Rainbow trial? Rainbow trial is zero point 0.2 ranibizumab versus 0.1 ranibizumab versus laser. Uh, there is a very simple injection. We have to give that injection 1 to 1.5 millimeter from the limbus. The injection effect is very rapid. There is lesser refractive error than laser, which was seen in the BEAT ROP cohort. There is no defined endpoint after the injection. When we have to stop screening, we don't know. There is a risk of end off with anti-VEGF anyhow, so we should always try to give this injection in the operation theater or in the full sterile conditions. The neurodevelopmental days, uh, the neurodevelopmental days uh, help us to correlate with zone 1 and zone 2 ROP. More premature the baby, more will be the neurodevelopmental delay, and more will be the chance of ROP in zone 1 or zone 2. And this is not related to anti-VEGF. Though some people say that anti-VEGF might go into the systemic circulation and cause neurodevelopmental delays, but there is no direct evidence, and this needs a prospective study to actually be seen. What are the phases of regression post injection? Post injection, so one is phase 1 is rapid quietening. In this phase, there within 1 week there is rapid neutralization of all the intravitreal anti-VEGF. The second phase is up to 11 weeks, 1 to 11 weeks, and this phase is slow vascular development. In this, VEGF secretions from the avascular retina or other growth factors are not blocked by bevacizumab, and there is slow vascular development in these areas. What is phase 3 of regression? It is from 11 to 16 weeks. A rich like classic ROP which can regress or progress comes. So this is the phase we have to watch again. So after injection, we have to follow up between 11 to 16 weeks again. So 2 to 3 months, we have to again call the baby for screening, even after injection. So next is injection with different lasers was done at Madurai Medical Center in Arvind Hospital, Madurai. There, the babies were treated with laser if no vessel growth was there even after the second injection, and dose was taken as 0.1 cc injection. Next option is the surgical. After lasers and injection, next option is surgical management of ROP. For surgical management of ROP, what is the most important need is a good anesthesia team, the NICU backup, because without these, surgery with just a retina person or a pediatric retina person is not possible. We need a good anesthesia team because the babies are premature. They are not adult people. Probably a pediatric anesthetist and an NICU backup is must. We have to operate early, especially if there is progression despite doing the laser therapy. At the time we at the time how we have to decide whether we have to go in for the surgery. If the height of the stage 3 height is increasing, that is, height is of the ridge is increasing, if the peripheral detachment is increasing, vasculature is increasing, and if the lens involvement is there, we have to operate. If there is a peripheral high TRD and we can't spare the lens, we should go for the surgery through the cornea. So, and what else we should be noting? First, during ROP surgery, we have to remove all the circumferential traction. Then we have to use diathermy over the ridge, and it's better to do laser marks before attempting surgery. When the baby is under GA, we can do a peripheral laser wherever we can, then start the surgery rather than doing the surgery and then doing the laser. So these three things help. Uh, Anti-VEGF can be given with the surgery, especially in the case of zone 1 ROP, and both eyes have to be operated in the same sitting, as we can't give again GA in a premature baby, and this is called as immediate sequential bilateral vitreoretinal surgery, that is ISBVS. There is risk of infection in doing a bilateral surgery, but compared to the GA risk again and again, this infection risk is less. What are the complications? Complications of this is subretinal cannula. The cannula can go subretinal, the pediatric cannulas, and the lens touch can be there during the surgery if we are not going the corneal way. Stage 5 ROP. Why can't we give the surgical trial? We should always give a try rather than directly telling no, especially if the parents are willing for surgery. Referrals. We, whenever a baby for ROP screening or ROP management is being synced, we should send it with a pediatrician or an ambulance backup. And we don't discharge and send a sick baby for the retina evaluation. If hemoglobin is less than 8, we should first do blood transfusion and then only send for a retinal surgery. Good NICU, good protocols in the NICU means less ROP. So ROP is actually tells how good the protocols are in the NICU. And all the pediatricians, the journal ophthalmologists should be aware of the medical legal liability and awareness. Next, we come to post treatment care of IOP. Once we have given the treatment, those babies become the ROP babies. Now, how to treat them in future? What are the challenges to us? There are many ROP sequelae like squint, high myopia, ocular morbidity is there. ROP babies are putting glasses. Neurological impairment is there in these premature babies, uh, and sometimes you can't differentiate whether it's a cortical visual impairment or ROP problem which is going on in that baby. So what we have to do is, first we have to see what is the age appropriate age of the baby. That is, we have to deal with the baby with the corrected age, not with the chronological age. The second thing is nystagmus or squint comes in these babies. Refractive errors are come. Normally there is hypermetropia in the babies, but in ROP babies it's myopia, which increases with age, and there is a chance of development of cataract. So this photograph is taken from a journal, Community Eye Health Journal, and this photograph is from P. Vijayalakshmi ma'am. And what it shows is the different visual developmental milestones. So at 3 months, babies start looking at the mother face and tries to recognize mother. At 6 months, tries to baby starts to try to touch objects. At 9 months, baby smiles at its mirror image and picks objects directly from the floor. At 12 months, the baby starts to stare at objects and tries to imitate other injections. At 24th months, the baby starts enjoying looking at the pictures, and at 36 months, the baby starts drawing. About myopia, here is a graph which shows the risk of the myopia and the age in months where it starts. When there is no ROP, there is low risk of myopia, and the risk starts at around 30 to 36 weeks, and slowly it increases, and still the risk is very low. When there is mild ROP, no treatment is given for that ROP. The risk of myopia starts at around 12 months, and it is much higher risk than baby with no ROP. But when there is ROP which was treated, there is very high risk of myopia, and this high risk reaches a threshold at 24 months. At 24 months, that is at 2 years. So this ROP which was specially treated, we should always evaluate at 1 year, 18 months, 24 months to do objective refraction. So myopia in ROP babies is multifactorial. It's because of the prematurity, it's because of the severity of the ROP, and it depends on treatment modality also. Cryo induces more myopia than laser, which induces in turn more myopia than anti-VEGF. The term babies In the term babies, axial elongation is the primary factor responsible for myopia, but in preterms, it's multifactorial as we have seen. The preemies, in addition to axial elongation, what else is there? The cornea is steeper, there is a shallow aces, thicker lens. So all these also contribute to myopia. Any role of low dose atropine in these preterm myopes? No, till now there is no evidence. Glasses, we prescribe according to the tailor-made approach. There are special glasses with bands, as we can see in this picture, so that the babies can see through the glasses. Once they are used to these glasses, they don't remove it. So it needs a lots of counseling for the parents that the babies will require glasses. We have to do appropriate cycloplegic refraction. We have to select the appropriate frames according to the age of the baby. We have to do frequent re-refractions. And there should be low threshold for prescribing glasses if the visual behavior is not age appropriate. So we have to remember those milestones which we just now discussed. So at 3 to 18 months and 18 months onwards, when to prescribe glasses? Prescribe glasses at 3 to 18 months of age if the sphere is more than plus minus 5 diopters, or if the sphere is more than plus or minus 5 diopters, or cylinder is more than 2.5 diopters, or there is anisotropy in both the eyes of more than 1.5 diopter, we should prescribe glasses at 3 to 18 months of age. And we have to prescribe on individual basis if the sphere is less than 5 and cylinder is less than 2.5 or anisotropy is less than 1.5. It's not compulsory. For more than 18 months onwards, the sphere of more than plus minus 3 diopters or cylinder more than or equal to 2.5 diopters and or anisotropy of more than 1.5 diopters, we should prescribe glasses. Only the sphere power is changing, not the cylinder and the anisotropy. And on the individual basis, we have to prescribe if the refractive error is same on two consecutive visits and which visits are 2 months apart, which these visits should be 2 months apart. These guidelines are also taken from Community Eye Health Journal. This article was from P. Vijayalakshmi. If there is ROP plus cataract, there is high chance of RD. There is high chance of RD in that eye. Late retinal scule. Late retinal scule is of ROPR, recurrence of ROP, a retinal fold post ROP, scarring, traction, or macular dragging because of the ROP, ridges, atrophic holes in the avascular retina, and the retinal detachment. What is a cortical visual impairment? In cortical visual impairment, we differentiate between low functional cortical vision impairment and high functional cortical vision impairment. And in CVI, what is important is functional visual assessment. Sometimes vision is low, but we can still function very good. That is high functional CVI. Sometimes vision is low and we can't function, that is low functional CVI. Eyes can be totally normal in CVI, and we have to order neuroimaging in the patients which come to us, and we diagnose it as cortical visual impairment. What is the treatment for ROP or CVI? For CVI, actually, visual stimulation and rehabilitation is must in CVI babies. There is a technique called darkroom stimulation, and this helps more stimulating the eye and in the same way stimulating the brain and in response. And the other thing is bright stimulation. We should always encourage our patients to go for the stimulation exercises so that they can be properly rehabilitated, especially the CVI babies, the main DD of ROP.